Good afternoon and welcome to Barriers and Solutions to Preventing Chronic Disease in Iowa, presented by the Iowa Public Health Association. My name is Janine Moody and I am the IPHA Executive Director, and I'll serve as the moderator for today's session. Due to the number of attendees on this webinar, all participant lines will be muted during the presentation. To submit a question for our presenter, please use the Questions feature in your GoToWebinar control panel. I will monitor all submitted questions and pose them to our presenter during the question and answer portion of the webinar. Today's webinar will be recorded and posted along with presenter slides. A few technical tips for optimizing your webinar experience. 1. Utilize a USB headset if possible. 2. Use a wired connection versus wireless if possible. 3. Close any applications on your computer which require large bandwidth. Now let's meet our presenter. Dr. Jeremy Whitaker is the director of the Public Health Undergraduate Program at Allen College. He started his professional career at Shasta County Public Health in California in communicable disease education and transitioned to the Iowa Department of Public Health, overseeing the statewide tobacco quit line. Dr. Whitaker worked at the Iowa Hospital Association as Director of Healthcare Policy before going into academia. He received an MPH from the University of Iowa and a doctorate in community health education from the University of Northern Iowa. Now we'll turn things over to Dr. Whitaker.
All right, thank you, Janine, and I'm just waiting. Can you see my screen?
Just
one
there we moment. Go. Okay, we can see your screen if you want to start your slideshow. There we go.
All right. Well, thank you, everyone. And again, my name is Jeremy Whitaker, and I have been around for a while, even if you haven't heard of me. Let's see. There we go. And again, there's my email address, and it'll come up at the end. And if you haven't heard of Allen College either, that's okay. We're up here in Waterloo. Our public health program is only about 3 years old, and I'm in my second year of working up here. So. But I had, like Janine said, I've been around the block at IDPH, worked at a local health department in California, and a couple other places here, even Wellmark for a little bit. So let's get started. Before I dive in to the first set of slides, I got 4 sections here. We're going to launch off about chronic disease. If I don't say something in the course of the next 20 to 30 minutes that doesn't make you a little upset, you may not be paying attention. So I'm not saying I'm out to stoke controversy, but you may not agree with me, and I hope you don't, and I look forward to some of those questions at the end. I won't be able to see them until Janine lets me have access to them, but please, as you're listening and saying does it seem right or bothers you, please type a question up. I'm really excited to hear them. So what's going on in Iowa for chronic disease? Here is an oversimplification of basically the leading causes of death and what causes them. Now, heart disease by itself causes about 22.7% of deaths in Iowa. Cancer causes 22.3%. So together, they're just below 50%. So that's really what we're looking at today. And now the primary ways to prevent those two are basically a combination of intervening with smoking, obesity, and for cancer, excessive alcohol consumption. Now, however, if you're preventing heart disease, by intervening with smoking and obesity, you're also preventing stroke and diabetes. So again, we're looking at kind of those actual causes of death of smoking and obesity. And when I talk about obesity today, I'll be breaking it down into physical activity and nutrition as kind of the 2 legs of the stool that are obesity and obesity prevention. Now, from those 5 diseases will kill 60% of Iowans. Again, mostly heart disease and cancer, COPD about another 6%, stroke another 5%, and diabetes about 3.5–4%. So combined, that is the majority of death. And we can delay, we can't stop, but we can delay the majority of death by, again, addressing those factors, specifically smoking and obesity, and of course, excessive alcohol consumption, which I'll talk about less, but it's still part of what we're doing today. So that's it. That's chronic disease. That's what's affecting Iowans. And to look at the specific stats about 6,000 6,600 people die from heart disease each year and 6,500 from cancer. So again, those are our big 1 and 2 here in the state. So now I'm going to do an overview of chronic disease prevention at local health departments. So this is a quote from Dr. Frieden. Dr. Frieden was the outgoing director of the CDC. This quote's actually a bit older. It's when he was running the New York City Department of Health. And he was saying back, again, over a decade ago, that local health departments must make the shift from communicable to chronic disease, and obviously that they aren't. And that was his concern even then. So looking at what NACCHO said the top services provided at local health departments. This is the top 10. Now, as you can see in this, there isn't a lot of chronic disease prevention. In fact, the only thing that could be considered chronic disease prevention is nutrition education. So of the top 10 services provided at local health departments, we're not addressing chronic disease. And I say we, I mean globally. I mean the whole country. If this list went on, number 11 would be tobacco prevention, right ahead of number 12, which is septic tank inspection. So again, to kind of give you an idea of where we at in the United States. So when I talk about Iowa here in a minute, I'm not really singling Iowa out. It's just that nationally, local health departments aren't built to do chronic disease prevention, and like Dr. Frieden said, really haven't made the shift. So again, this is part of a research study I did and using some data from all over, I'll talk about here in a minute. And I just asked the question, are county health departments preventing chronic disease? So we did the 2014 Public Health Survey, which was a self-report sent to all the counties. 55 returned it, but I threw a couple of them out for very study reasons. So I analyzed 53 of them. And here's what they said. Does your health department prevent the primary prevention of chronic disease? 43% said yes. Does your health department do primary prevention for nutrition? So again, you're seeing less than half. And again, this is a self-report. Then I analyzed annual reports from all of the agencies in the same 53. I pulled up as many of their annual reports as I could get my hands on. Some were emailed to me, some I was able to find online. And these, I was looking for mentions of activities related to primary prevention of, again, what we talked about earlier, smoking, obesity, and excessive drinking. And here's what you see. Again, less than half across the board. Some areas more than other. Tobacco, you're going to see more, but a lot of that's because you have tobacco partnerships operating in 94 counties. So again, with such a high funding at a local level, you should see higher responses in tobacco. And then finally, I looked at the health improvement plans for the county, those same 53 counties, and only 51 were available. And these are the ones who mention these in their plans. So you're seeing a higher rate here of people who are counties that want to tackle these issues. Still around 50 or below 50% for most categories, but you are seeing some, things here where there's a huge spike from the people who said they want to do physical activity prevention to those who planning, a doubling. So again, there you see a lot of trending in the right direction of people who want to do and departments that really want to pick these up. But again, it's not happening consistently across the board. So let's look at those barriers, because after you see these, it's amazing that any chronic disease prevention gets done. At least that's how I felt when I looked at the data. So again, here's from the Institute of Health, their landmark report, The Future of Public Health from 1988. It's impossible. You can't serve that many masters. You can't, avert disasters and provide personal care, and again, with no money at all. And it's amazing that anything gets done at all, with all the competing demands for the time and resources that local health departments have to face, especially those that would consider themselves rural. And, it's one of those that basically the median population in Iowa for a county is 15,527. So half of our counties have less than 15,527. I was on the phone with somebody from a health department. Like, well, we're a pretty rural county. We've got 25,000 people. I'm like, actually, you were probably near the top third of population among counties in Iowa. So again, I would say below about 40 or 50, it's hard to provide comprehensive services. Just because, again, the needs are often too great, the staffing too low, and the funding too little. So let's look at what the state mandates county health departments to do. Number one, they have to cover gaps in healthcare. They have to coordinate with animal control. They have to provide immunizations or make immunizations available through private resources. They have to test and report lead. And they have to do inspections of restaurants, pools, and tanning beds. Good list, but nowhere do you see chronic disease prevention. The only thing that approached it was actually removed from administrative code. Breast cancer was in there for a few years and then was later removed. So again, you're not seeing any requirement from the top down requiring or asking for chronic disease prevention. And also, it's just not a priority from a budget standpoint. This is the Iowa Department of Public Health 2017 budget. I broke it down looking at different areas. So we'll actually start at the bottom. That $15 million is what I would consider direct spending on chronic disease, not necessarily primary prevention, just chronic disease. So that includes cancer, heart disease and stroke, nutrition, physical activity, diabetes, and tobacco use. So all of those combined is $15 million, all of those divisions and bureaus. Now the indirect spending, I thought I was fairly generous. In this bucket, I included local public health services, adolescent health, health statistics, healthcare safety net, minority and multicultural health, planning services. So anything that may incidentally positively impact chronic disease prevention. I gave WIC its own bucket. It's the biggest program at the State Health Department. I love WIC. I was once a WIC recipient as I was in college when my second daughter was born. Now, is it a chronic disease prevention program? I don't know about that. So I kind of gave it its own bucket. And then all other spending at the State Health Department is $177.5 million. So looking as a percent on this, that chronic disease prevention is less than 6% of what the health department spends every year. If you add the direct and indirect together, you're still looking at less than 14% of the entire IDPH budget, even though 60% of deaths are from chronic diseases. Or one more depressing way of looking at it is, this past year we had $10.5 million for AIDS and $15 million for chronic disease. Now, as you might guess, the disease burden was a little different. So again, what we're spending for HIV, and I'm not saying we should stop spending money on HIV or stop applying for Ryan White funds from HRSA, because again, we want the money rather than not having the money. But from the top down, the way the money comes in from the CDC, it is appropriated more heavily towards emergency preparedness and HIV. Emergency preparedness this year was $11.1 million, which was more than tobacco, nutrition, and obesity, physical activity combined. Almost more than all chronic disease combined, just for emergency preparedness. So again, you're not seeing the money come from the federal government to the state in a way that addresses chronic disease even close to proportionally, and so then the IDPH budget also reflects that. So another barrier, especially for the rural counties, and by rural, I mean, again, I'm talking anybody under 50,000. At least when I broke this down, the rural and micropolitan are less than 50,000. So the per capita spending is, well, much, much higher for rural counties than metro counties. And also, metro counties get more money in local tax. The 5 metro counties in the study had almost half of their budgets come from county revenue, usually property taxes. Much, much more than you see from the rural and micropolitan areas. So anybody less than 50,000 is getting a much smaller piece of the pie from local sources. And it's a shame because local sources are the ones that can be used to fill in those gaps in chronic disease. Where the money's not coming down from the CDC through the state to you for chronic disease prevention, you could theoretically make it up with that local spending. But again, local health departments get less of it. And again, maybe one of the reasons they get less, is because their cost per person for a county under 10,000 people is $90. It's a fairly large ask for your Board of Supervisors when, say, a Polk, Lynn, Johnson County is requesting around $27 per person for funding. So again, it's a much smaller ask, and I think you're going to get it more likely for someone to say yes to that. And also, you're going to see an inverse here. The number of FTEs versus the number of full-time employees per 100,000 population. That, again, you just don't have that kind of economies of scale where, you can get a lot more staff in a large health department and still have a smaller proportion of the population. And then another barrier, switching gears completely, and again, they were asked the question on the 2014 Public Health Survey, does the department use evidence-based practice for, and they were asked yes or no, check the box or don't check the box. And you're going to see numbers, and again, you look at that last column across the board, under 50%. The evidence-based program isn't being used. Now, on those first two, for cancer and cardiovascular disease, that's a little bit tougher of a question, because usually evidence-based program to treat a disease involves, well, actual medical treatment. But those last three are really what I'm more focused on. Nutrition, physical, and again, tobacco control, tobacco prevention. Those are the numbers where our traditional public health prevention areas, and we're still seeing, numbers below 50% across the board. Again, slightly higher in the bigger counties, but not drastically. And again, particularly low is that tobacco number, because again, there are 94 counties have partnerships operating in the area that should be using evidence-based programs. And again, that across the board number of below 50%. But it's okay, because I have some solutions. I hope I do at least, because we've seen the barriers that it's not getting done at the rate it should be. Again, less than half of counties, pretty much in every category, are not doing chronic disease prevention. So I think I have some solutions from the literature that may work for some of you. But I want to start off talking about the community guide. If you have not been to the community guide in the past year, your homework for tonight is to spend 20 minutes going through the community guide. Go to the website, thecommunityguide.org. It's run by the CDC. It condenses best practices for a lot of area, and you can click on topics, pick a topic that you like, and then you can sort through interventions that are either recommended, have insufficient evidence, or are not recommended, things that don't work, and to have an idea. Now, I had my cheeky little comment there that it's cheaper than getting an NPH, but it really should be, if you're thinking about interventions and evidence-based interventions, your first stop. It's not the only place to find these, but it's the best place I've seen them consolidated. And it's going to save you trying to hunt through literature, which is hard to do, honestly, if you're not in a college and have access to all the cool articles. So please go there. And here's my user guide for you to use the community guide. Step 1, select a topic. Again, here are all the different areas that in chronic disease that are listed. Now, some of these interventions are going to overlap. If you look for something for obesity, you're probably going to find some of the same things under nutrition and physical activity. So go ahead, take a look through these, see what's out there. Number 2, select a recommended intervention. Again, there are those 3 categories. You make sure you're looking through the ones that are, in fact, supported by evidence. Now, I was recently at a conference, and one of the things, it was actually the former director of the Maryland Health Department, and he said that sometimes in public health we get a little hung up on p-value, and that not everything that is good and can make a difference has a p-value of 0.05 or less. Now, those are things that have strong evidence behind them, but let's not let doing good get in the way. we can't find a perfect solution for everything. A good solution is sometimes good enough. So again, look through those. If you have an idea, try to find some evidence to support it, or somebody else that's done it or used it as a best practice. And then number 3, of course, would be implement. So select your topic, find an intervention you think will work, and implement, but please, please, please get someone to help you, because it's basically trying to be a one-man band and beat the drum for public health is going to fail 9 times out of 10. Talk to people behind the scenes, talk to your board of supervisors, line up some people in the community who are interested and passionate, or at least, groups that won't put up a fight. If you're going to make, for instance, a cancer intervention where you have in the building code that houses must be radon resistant, talk to some local builders before you do that. Or if you're going to have that every house must have a radon test as a condition of sale, much like termites are required in Iowa. Again, talk to the local realtors and other parties before you go off and start tilting at windmills, because these are good ideas, but trying to do it all by yourself is probably not a good idea. So policy really is going to be your best friend. I'm not big on education and messaging. If messaging alone was enough, I'd be 40 pounds lighter and just get done training for a triathlon. Neither of those things are true. So again, policy is really the sweet spot, and I'll explain why. Here are some real things in Iowa policy successes. Now, the smoke-free air law. Again, hospital admissions for acute MI, more than a 40% drop. It actually might have been 47%. I couldn't find the statistic. If you want the statistic, email Geraldine down at IDPH and the tobacco division, or your local tobacco partner. Hopefully they have access to it. It's a study Dr. Squire did a few years ago. I didn't cite it because I couldn't find it, but I assure you it is true. So food stamps at farmers markets. Again, in 2017 so far, over 2,200 transactions. Now, that's not saving the world, but it's a good start. And that's definitely a place for growth, where if more vendors at more farmers markets take EBT, then you're going to have more utilization. It's like striping for bike lanes. You got to stripe before the bikes show up. You can't, just look for the streets that already have bike traffic and then stripe them later. So you kind of have to dive in on this. But that's about 10% of all card transactions, credit card or any type of card, were EBT. So again, from 0 to 10% in a very short amount of time. So, and then finally, baby-friendly hospitals and increasing breastfeeding rates by changing hospital policy. Again, we can talk to mothers until we're blue in the face, but if hospitals are going to, really trend towards formula and away from breastfeeding and not put policies in place, you're not going to get anywhere. And again, by all means, when you're done with this conversation, you can Google Genesis and Mary Greeley have both got their baby-friendly certifications. Now, not every hospital in Iowa, and I believe there are about 125 of them, not all of them have, labor and delivery, but really focusing on the ones in communities that do can make a huge difference. Those mothers who are breastfeeding at day 7, because if not breastfeeding at day 7, they're definitely not going to be breastfeeding at 6 months, which is the standard. So, trying to get in early in those policy change. So those are just 3 examples from Iowa, but this is from the literature, all of the different things for the topics we've been talking about that local health departments should be taking the lead on. And I have the sources down the bottom right-hand corner, and you can look at this last slide. I didn't make this all up. And again, almost all of these are policy-based initiatives. Not 100%, but again, limiting tobacco sales or density of tobacco licenses, or encouraging retailers to give up their tobacco license. A lot of efforts been with CVS and Walgreens as drugstores to stop selling cigarettes. Target stopped selling cigarettes a long time ago. So there are, because it's easy to have that conversation with the manager and say, do you want your kids to smoke or your grandchildren to smoke? So again, some of those are possible. And again, getting youth involved in prevention, obviously, which used to be GEL and is now, I believe, ISTEP. Again, I worked at the tobacco division a decade ago, so my knowledge is a bit rusty. Uh, Looking at excessive alcohol consumption, again, density of liquor licensees, where they are, how close they are to one another, things like that. And then for obesity, again, being physical activity and nutrition, again, a large number of things. Active transport being the fancy way of saying walking and biking to school, a number that has plummeted from nearly 50% in 1980 down to about 4% today. So again, things that we need to move the needle back the other way on. And again, we talked about breastfeeding and policy. Whether it's businesses having breastfeeding rooms, and encouraging, and that can be, of course, part of a worksite wellness. This is things that need to happen at the local health departments. The state cannot come in and help you work with a company and encourage them to do a worksite wellness program. There just aren't enough people and not enough money for mileage. So you're going to need to get in there and really be part of it at the local level. So I'm going to talk about the least favorite thing that people are going to enjoy today, which is regionalization of public health services. All right. So the Iowa Comprehensive Health Plan, you're like, who are these people? Well, I'll tell you. They identified two major problems in health departments when they did their study. The first, not enough money. That should come as a surprise to no one on this call. Number two, county populations that are too small. And again, we talked about the problems of they need more money per person to run a small health department than a large health department. So again, these are really familiar ideas. What is better, for better or worse, this report is 40 years old, and really nothing has changed in the recommendations from what we need today and then what we needed 40 years ago. We're basically doing the same thing. We're running, over 100 health departments in a state that probably shouldn't have 100 health departments. And again, with the median health department serving less than 15,000 people. And so again, trying to run, do evidence-based practice and hit all of these topics, it's impossible. They knew it then, we know it now. So again, we already saw this slide, like I said, the per capita spending of $90 at a rural health department versus $27 at a big health department. Again, this was predicted 40 years ago, and it remains true today. So here's a crazy plan to regionalize public health. A guy named Haven Emerson wrote a plan for all 50 states. And this is what he proposed for Iowa. And so you can see 27 regions. The smallest in population would be 50,000, to the largest being Polk County. So the red counties are standalones. Everybody else is grouped. Now, what's interesting about this plan is that it makes a reasonable amount of sense now. This plan was proposed in 1945 and presented at the Iowa Public Health Association conference and endorsed by the director of the health department. So this was the plan for Iowa back in 1945, but it was a little ahead of its time. Most health departments, as we know them, really didn't get started until the 60s. At the time of this report, only 6% of Iowa's population was served by a health department. Now you had nursing, you had public health and nursing, but more in a clinical role, not that they're not today, but, and so basically in the late 60s, you had to have a health department. And so in the 1970s, the map looks very similar to today. So we've kind of had our current system for about 40 years, but this was proposed before my parents were born, and actually still makes a fair amount of sense. So you have, again, good-sized health departments that could theoretically serve at least 50,000 people that aren't geographically ridiculous from one another. Now, I'm not saying it would be a popular idea or that we should do it tomorrow, but it is something to think about. So we already have regionalization. And I'm not talking about the IDPH maps and the 6 regions. Those are artificial. I'm talking natural opportunities where people have gotten together and created partnerships. Now, for instance, you have 18 tobacco partnerships that cover multiple counties. I said 94 counties had one, and I believe that number's right. And the American Lung Association out of Des Moines covers 8 counties. including several very, very rural counties. And by covering that many counties, they have enough people to have a couple of staff people and make it work. So again, that's just naturally occurring. Those 18 different organizations covering multiple counties, some covering 2, again, some covering up to 8. Black Hawk County does the food inspections for 10 counties. And if you include licensure for tattoos and pools, it's even more. And again, a naturally growing agreement that came out of a need. And then in Southeast Iowa, you've got 3 counties working together on their public health accreditation. So again, naturally, were they already, well, one, to defray the cost, because $25,000 for accreditation is a little much to carry on one's own, especially if you're a smaller health department. And again, the other idea is that they already knew each other, they already worked together, they already had agreements and collaboration. And so with as many health departments and as low as a population as we have, it's natural to reach across borders and collaborate. So some of that is already happening informally, some of it is happening formally. And I'm not saying that we should go to the map of 1945 and make 27 health departments, but I'm saying over time it is bound to happen. And I don't know what the map's going to look like in 10 or 20 more years. Will the rural areas be more rural? Will the cities be more dense? Probably. So again, you'll always have pockets. Wherever there are jobs, there are people. So, any rural area that can attract a major employer, less likely to need a regionalized, but I think over time you're going to see that trending even more so, and neighbors needing to rely on each other even more than they do today. And of course, here you go. Accreditation does include a standard about chronic disease prevention and calls out tobacco, nutrition, and physical activity. So again, these are going to have to be in plans. And the cheapest way to do it is to have a policy initiative. Policy initiative costs nothing. It takes time, and it's gradual change. But again, a policy initiative costs nothing. And that's actually in my summary. Chronic disease kills most people, but it doesn't get the funding. Infectious disease, environmental health, emergency preparedness all get more money. They get more staff, and they get more attention. Health departments, again, they are struggling because there aren't resources out there. Money isn't trickling down from the top. There are no mandates to do it. And again, when your house is on fire, you're not going to, plant a garden. You need to do the things that you need to do just to get by. Especially things like home health and other critical services that the community relies upon public health for. Policy, again, I'll say it again and again, it is the most effective answer. Messaging doesn't work. 98% of smokers know it's bad for you. We don't need messaging. We need resources. We need environmental shift. And again, regionalization can help with inefficiencies. You don't have to combine to regionalize. Again, you can share employees across jurisdictions, things like that. Shared services, those type of things. You can regionalize while maintaining your individual identity. And so at this point, I have talked for about a half hour dead on, and I really hope to hear your questions.
Great. Thanks so much, Jeremy. So just a reminder to everybody and those who've hopped onto the webinar since we began, the way that we'll be handling questions for Jeremy will be for you to submit a question using the questions feature in the GoToWebinar control panel. So that's that little annoying thing that keeps sliding over into your view of the slides. If you click on the orange arrow, that will expand it, and there's a questions feature there, and we can get those typed in, and I'll start reading those to Dr. Whitaker. One thing, Jeremy, I wanted to add, thanks for the review of the community guide. I think that is an all too underutilized resource in public health and beyond. And another iteration of the community guide, or another tool that's pretty simple to use, and I recommend in our coalition work often, is What Works for Health. And the What Works for Health resource is on the County Health Rankings website, and one of the primary sources is uses for the evidence-based strategies that are organized by topic area is the community guide, in addition to a few other things. So that's just another plug for that resource.
No, absolutely. And in fact, I actually overlooked my notes, and I had the Institute for Public Health Innovation as
All right,
another great resource as well.
good deal. All right, so I'm going to go ahead and take the first question, and I will point out it is the one and only question. So let's get typing, people. Let's go ahead and get those questions out there. And remember, Jeremy hoped that he would challenge you and engage you in a provocative way. So go ahead and share those thoughts back with them as well. Our first question is from Sarah Comstock. Hi, Sarah, from American Cancer Society. Sarah asks, what are your thoughts on the specific barrier of transportation as a health determinant? What do you see as trends and applications we can do in Iowa to improve it?
Well, you've got a couple of things because cancer treatment is very much a scattered enterprise. People receive treatment at large facilities, and then, of course, they live everywhere. And especially because you have even a bigger deficit is that rural counties do trend a little bit older. So you're probably going to have a disproportionate share of cancer in rural areas further from treatment. Uh, and so the answer is nobody has solved this problem yet, and I am probably not going to be the first. You do see, obviously, resource sharing between hospitals where people, maybe they go to Iowa City for their major visits but get a lot of the follow-up treatments more locally. But there isn't a good solution, and it's never something we're going to solve because we are lucky in Iowa that we don't have giant mountains or things that prevent people from getting anywhere. And the fact that you're pretty much only an hour from treatment no matter where you live is actually really, really good compared to many other states. And that our geographic spread, although Western Iowa a little less, again, you're still probably, it's hard to be more than an hour from a major hospital or, level one or it's been a while since I've worked at the hospital association, so apologies if I don't remember. So it's more of a treatment issue, which is not my specialty, but I would say we're going to have to do better with. Unfortunately, it's going to have to be telehealth. It's going to have to be other remote medicine because we can't build bigger hospitals out in rural areas. It's just not sustainable.
Okay, thanks, Jeremy. And I'll take just because I guess I have moderator's privilege here, I'll throw out a couple of thoughts as well. So in terms of prevention and thinking about chronic disease and social determinants of health, transportation is a really key social determinant of health, as you point out, Sarah. And a few resources that I would like to have us be considering. Most of you as members know that IPHA has been partnering with the American Planning Association, the Iowa chapter, for a couple of years now on a couple of different grants, and we had some demonstration projects in Linn County, and those are on our website under Hot Topics, Planning Healthy Iowa Communities. But definitely thinking preventively from a planning and design perspective. A couple other resources I would point out to you. The Network for Public Health Law did a really great webinar on this topic in March of this year, and it is posted to their website. So it's been recorded and the slides are all there. That's another good resource. And then also APHA, we're an affiliate of the national organization APHA. On their website under topics and issues, they have a whole page dedicated to transportation and health. And I think there's some good resources there as well.
Mm-hmm. And honestly, what it's going to come down to is now is probably, again, this is a treatment issue, so somehow it's going to have to be a covered expense in health plans, one way or another, Medicare, Medicaid. And again, before that happens, and that's sometime off in the future as we tackle social determinants, and social determinants become a bigger piece of health care. I think, again, we talk about Linn County and Polk County, I think that's definitely nothing that they can crack. They have buses and established companies and an Uber presence and, resources that can really handle it. I don't know that Uber is the solution in Ringgold County. On the other hand, a health plan that reimburses somebody for something like that is going to go a long way. When there's reimbursement, services will follow.
Good point. Okay, next question comes from Jenny Edgar. Hi, Jenny. Is there a county, particularly a more rural one, that you judge is doing better at reacting to chronic disease than other counties? So, Jeremy, do you have a gold star or a case study you could share about one county who's a rural county that's doing a particularly good job?
Um, yes and no. Unfortunately, the information I had to analyze was confidential, so I'm not supposed to share any particular county that's doing well. But I'll point out, I don't know that it's silly, but I'll just go with it. Ringgold County has a better website than most any county I visited. And I'm talking Lynn County, Polk County, things like that. That is your doormat. That is your welcome. That lets people know what's available. People are going to search your website when they're looking for services. They're going to come across it. And it's really disappointing to see how, I would say, perfunctory a lot of them are. It's talking about low-hanging fruit and something that doesn't cost a lot of money is updating a website. You know, people do it with their blogs for about $12. You can buy a website name, link to it from your county website, and do a 5 or 6 page informational, useful public health website. So I will say Ringgold as a shining example of what a very small staff can do when they're motivated. Now, when it comes to programming, it gets a little tougher because a lot of what I saw, and it kind of piggybacks on what I talked about with the evidence base, a lot of the things that I did find were not evidence-based, good activities, but nothing that's going to address problems long term. One-off education things with the Hy-Vee nutritionist. It's good, but it's not, again, it's not, messaging isn't enough. Helping people cook one healthy meal isn't really going to move the needle. And so, I would say that I really didn't see policy at the local level in any real substantial amount. And I guess that's what I've been, again, that is my meat and potatoes and where I think the change is going to happen. When you see drastic drops in health status, it's because of policy. I was talking with Janine before this about the 10 greatest public health achievements. I forgot to put the slide in on it, but almost all of them are driven by policy. You see a decline in automobile deaths. It's because, not just because we told people to wear the seatbelts, but we made it the law. I mentioned the drop in tobacco use, drop in acute heart attacks after the smoke-free air law. You see immunizations, again, because there's a law. So I think we need to be not afraid to use the stick a little bit more than the carrot. Education's good, but long term, it's better to change the system in which we live and then educate people to it.
Okay, thanks, Jeremy. Next question comes from Dr. Welk at ISU. Thanks for joining us. He asks, has there been consideration of county alignment with county extension offices? Seems like a logical connection and would have mutual benefits. How can we encourage more public health and provider? Oh, I'm sorry, went into the next question. Let's stop there. So county extension offices aligning and partnering with public health.
I think so, because they do have, one, a fairly large presence in many or most counties in Iowa, especially the rural areas. You already see partnerships between local health departments and hospitals. Some good, some bad. Sometimes the public health is shuffled in as a department under the hospital and gets almost completely lost. I've seen that in a couple of other counties. But I've also seen other places where, without the overhead cost, that they're able to do more, and that they have access to the hospital's resources. Now, using that same template and applying it to an extension office, it would make perfect sense. I know one county where the health department's technically one person, but there is a local agency who basically acts as the de facto health department for everything but infectious disease reporting. So I think you have a couple options. One, again, absolutely leaning on the resources, the space, to basically either combine or partner in the rural areas especially. And then secondly, for even potentially for counties to sign over their health departments to an extension, or an extension office to take over for a couple of counties, or to provide that radius of services because they're less jurisdictionally bound than most health departments.
And Dr. Welk, and for others as well, I'll just throw this out there that I've been representing IPHA on the Healthiest State Initiative, that 2.0 version, and that's been restructured, and serving on the Community Health Improvement Committee. And that group has, in the last 2 meetings, talked about how do we connect with county extension offices. So I think that there's an appreciation honoring that establishment of those as a system across the state and a desire to work with them. So maybe you and I could connect about that after. Let's keep going. So we still have a bit of time. So if people have questions, keep typing them in there. We'll move on to the next one, Jeremy, from Kathy Kunith. And Kathy asks, how can we encourage more public health and provider partnerships, primary care, to work together on chronic disease prevention and management?
Yeah, so we're starting to move into that secondary level of prevention. Primary, of course, stopping things from happening, and secondary prevention, catching things rather early, in case of cardiovascular disease like, blood pressure. A lot of it for providers, obviously there's the reimbursement issue, and it's always been a thing where they have 7 minutes with the patient, and that's all they get paid for. And so anything beyond 7 minutes are basically donating their time. And so trying to find ways where they can do that at a cost-effective or free level, there are ways. When, again, I was at the state, we worked with the Primary Care Association to integrate tobacco screening into their medical records. And so patients were asked on every visit, have you used tobacco? So, there are issues, flags like that, where it generates a conversation, an organic and natural conversation. But by changing the system in which they work in, you start getting those flags. Or, has anybody talked to you about your weight? Or do you feel uncomfortable about, those sort of things? Or would you like help? Those sort of things, those kind of ticklers in the record. Another project we're working on actually out of Allen College, where I'm sitting at, is where clinics ask if people have had trouble making ends meet. At the end of do they have any money left at the end of the month for essential needs? And that question basically prompts a visit to a social worker and then gets people into social determinants of health. So again, something that you build into your electronic health record that, again, organically starts these conversations. So asking providers to go to do extra is going to be really, really hard. And they've already got to, pay all their staff and their malpractice insurance and deal with insurers. One more thing is not going to be welcome, but working with systems, or if you have independent providers, maybe that's a little easier, or small systems to start integrating those either social determinant questions or those direct health questions that address things, again, like tobacco use and obesity.
All right, and I guess another plug for another important project here in Iowa is this. Most of you are probably familiar with the Statewide Innovation Model, or the SIM projects, and those 3C projects. And a number of them, there are specific topic areas like tobacco and obesity and social determinants of health, and a few other things that have developed statewide strategies, and they pulled together a number of planning groups with representation from public health and primary care and others to talk about what, again, going back to the community guide and what works for health, what are evidence-based strategies, and then making those statewide strategies, different components of them are implemented out in the community with public health, but some that are implemented in the primary care setting. So I think that's another good resource to take a look at those plans. Okay, I'll just say we have 15 minutes left. We have another question in the queue. Oh, a couple more. Okay, this one's from Linnell Deers. Hi, Linnell. The regionalization map intrigues me as to how public health may progress effectively, since many rural counties have fragmentation of public health services locally and state held. For example, tobacco and alcohol services by economic organizations, lead and restaurant inspections by the state. What are your thoughts?
Well, theoretically, and if they make me king of Iowa tomorrow, what I would probably do is create regional health departments, but leave a county office for those direct services where you need them. Again, home health, things like that. So there's a footprint, but where you're not duplicating administration and leadership across multiple jurisdictions. Hopefully there's a little bit of cost savings there. And then also when you have a bigger district, you can apply for grants that cover bigger areas, bring in more money. You know, it's a crime that we have probably less than 5 epidemiologists working at local health departments across Iowa. Again, there are regional ones for the state, and there are plenty who actually live in the Lucas building, but you're not seeing those kind of specialists out in the field. And again, I think if you create the jobs and pay them decently, that people will follow the jobs, at least to some extent. So I guess what we need to do, but I'm not king, and so looking back, I think what counties need to do is start looking to their neighbors and use public health accreditation as a jumping off point. Now, the Iowa Code has nothing that stops counties from combining health departments. You guys could do it tomorrow if you want. You can read through section 137 of the Code of Iowa, about halfway down. It talks about health districts. The law's only ever been used once for the Siouxland Health District when a city and county combined, but absolutely nothing prevents counties from joining together. So with that in mind, start looking at where can we share resources, where can we share administration, where can we cut costs. Now, theoretically, if you can cut costs and keep the same level of services or increase the level of services, that should intrigue your local boards of health and your local boards of supervisors. So again, I think it's already going that way. And again, that map from 1947 is interesting in the idea that it held true. You know, 70 years later, it still works. And that we would have a district with no less than 50,000 people. And generally speaking, the ideal health department is described in the 2012 IOM report. And it talks about, you know, cross-cutting across different areas. You have an epidemiologist who doesn't work just infectious disease, but all areas. And a communications team that doesn't work just tobacco, or it isn't siloed in one area, but all areas. And so trying to build those health departments in jurisdictions of less than 50,000, it would be impossible. So theoretically, we could streamline them without adding more money, make our services maybe a little bit better and more regionalized, because then maybe the health department, not as much money would have to be kept up top and more could go out, theoretically.
Okay. And just a follow-up point that Kathy Kunith was sharing back from her previous question around primary care and public health collaborating on chronic disease. She points out that with value-based healthcare, ACOs will be responsible for population health and will need more community-based partners. True enough, Kathy. So any thoughts about that, Jeremy?
Oh yeah, no. Obviously, value-based purchasing, lowering readmissions into the hospitals, it's a big deal, and absolutely taking a 1 or 2% cut to your Medicare reimbursement because of your readmission rates being too high. That got everybody's attention, and so health systems, they're doing better now about talking to one another and caring more what happens to the patient after discharge, and so you're seeing care coordination, which was a virtually non-existent field 20 years ago, now starting to actually be a viable career path for people. So you're going to have people who can talk healthcare and walk people through the system. Whether the fact that our system is so complicated, we need people just to explain it to you is a whole nother issue, but at least they're there. And so then there's money in having care coordinators, and there's also more money in end-to-end solutions of, you know, having not just the hospital, but having the rehab center and having, you know, all the pieces on the board and keeping that under your control and in your EHR. So yes, I think because of that, you're going to see big health systems grow even more.
Okay, and this is again the last call for questions. I'll give it just another 30 seconds or so in case someone's typing in. Otherwise, we will wrap up and give you back 15 minutes of your lunch hour. Okay, well, then first of all, I'd like to thank you, Jeremy.
Okay, it's just us, right?
Yep. No, well, no, everyone's on.
Okay, hi everyone. Sorry, they're dropping off.
No. Yeah. Just wanted to thank you for spending time with us today and for sharing your research. On behalf of the Iowa Public Health Association, I'd also like to thank all the participants for spending this time with us today. If you're an IPHA member, thank you for your investment in our collective work and mission. If you're not yet an IPHA member, we invite you to join us to support our work to build the shared value for public health in Iowa and in our nation. Thank you and have a good day.